Welcome back. We're going to be talking about treatment of the thoracic spine today. When you're treating the thoracic spine, you're still going to apply all of those concepts that you learned in gait last semester, and we talked about posture and also foundations. You need to address the patient's posture and take care of those muscle imbalances. So you may have specific stretches, strengthening, consider a Yonda upper cross syndrome. As part of that, if they're thoracic and or cervical spine, and even lumbar spine, if they have hypomobilities and stiffness, then you need to mobilize that and maybe even use thrust grade 5s. Once that thoracic spine is now mobile, they have a better chance of holding good posture. But again, let's say their pecs and some of those other muscles are shortened, then you need to stretch those things out. As those are stretched out, then you can focus on the endurance aspect in terms of, say, your lower trap, your scap retractors, and some of those inhibited or underused muscles. You then can work on strengthening or the endurance of those. Sometimes you can use different things. They have certain shirts now that cue posture, that have stretch built into certain places of the shirt. It's very important to talk about breathing, such as focusing on that diaphragmatic breathing. That helps with chronic pain patients as well. So you may be cueing using their stomach to do the breathing, or their abdomen, as opposed to the upper traps, SCMs, scalenes, and all of that. And then those might be areas you need to relax, because many thoracic spine patients may have that thoracic pain as well as, say, neck pain or headaches. So that can all help. You can also use that originally called kinesio tape, but rock tape and many other forms of tape. And you can put on that tape in a way sometimes to limit their posture, but I tend to like the technique of just putting on a partial stretch so that as they get into that forward head posture, they'll feel it stretching on their back, which will then cue them to sit up straighter. From there, we move into mobilizations. We went over plenty of those before we all went into quarantine. We went over the I Dream of Genie position and some of the mobilizations there, assisting with that rotation. Those were all part of our test. We also had our grade 5s, of course, the supine, prone, wall technique. So plenty of ways to mobilize the thoracic spine. Ones we didn't necessarily practice that we talked about with the assessment last week would be the PAs. So similar to the assessment, actually it's exactly the same. You could apply those similar PAs using the thenar eminence and just spending a couple of minutes in any of those positions where you find that tenderness and hypomobility. So add that to kind of your bag of tricks when it comes to mobilizing the thoracic spine. Specific to that then, once you've mobilized the thoracic spine and gone out to the costotransverse joints, if somebody still is experiencing rib pain, maybe more laterally or even anteriorly, if the posterior structures are good, then I tend to move into the soft tissue. And I mentioned this in one of the videos. Once you've relaxed that soft tissue, and that can simply be done by, it's kind of like scooping. Essentially, you find those ribs, and then you just, almost like you're going in, digging in, trying to scoop out something out of that groove. You can just sit with a nice flexed finger and dig into those intercostal muscles. I say dig and just because if that's actually the problem, it's going to be very tender. So definitely proceed with caution. Not that you're going to hurt anything, but that it's very tender, and they might prefer to have a few treatments of you being gentle to relax those muscles instead of one, and then they never come back because you tortured them. I've also found that the IASTM, the Graston or hot grips into those grooves tends to help as well. So that's more advanced coursework that you could do. But once you've done soft tissue into those ribs and you've mobilized the posterior structures of the spine and ribs, now you can go after the actual ribs themselves. In this case, what we're imagining, if this would be, say, and I think, let me look on this, let's imagine this is the third rib, the fourth rib, the fifth rib, and the sixth rib. Well, as you're going along doing the assessments we went over last time, you may be looking at these spaces and you notice a good space here, not as good here, and then another good space here. So you're imagining that fifth rib is cranially locked into the fourth rib. Well, if you could hold on to that fifth rib and pull it down, at the same time you're trying to pull the fourth rib up, then you have a good chance of mobilizing that segment where it's essentially stuck. So there are a few techniques in the videos to show you how to do that. From there, we get into soft tissue work and a few exercises. So hope you enjoy the videos. I will post these slides. You can read these more detailed, but these are ones we go over here. This is that upper rib mobilization, going for that separation, using breathing and using the distraction of the shoulder to help that, in this case, that fourth rib, or I guess, yeah, the fourth rib stay cranial while you're holding down, in this case with that thenar eminence, holding that fifth rib more inferior. Similar thing here, using the thumb, using the web space, whatever ends up working for your comfort. Try a few different techniques and see what works best for you. But for those lower ribs, same thing. If 8 is locked on 7, you hold 8 down, while then you're distracting that shoulder, which is trying to pull 7 up. But since I'm not letting this come up, then it essentially gets mobilized and opens up that gap there. If you imagine breathing it, it applies much the same technique. But that's all explained in the video, so hope you enjoy. Okay, first we're going to try our upper ribs mob. On the slide it says the separation one. With this, we're imagining that as we're palpating along, if they had pain, say in this region, that we found that one segment was tender and that it was a little bit closer together while the other one was further apart. So just to choose a number, let's pretend like we're on the fifth rib. So this would be rib 5, this would be rib 6. And the gap is smaller together there, where everywhere above and below, it's the normal width, just like you kind of see with the width of my fingers there. So what I want to do is actually come down and pin down that lower rib of the two that are stuck together, and I'm going to hold that down. Well, as I do that, as I pin down where my middle finger is here, and we distract and pull and stretch and breathe and do all these other techniques for the upper rib, then that separation will occur and you'll actually get a gap there, where right now it's again close together. So again, we're imagining C6 is stuck on C5, so I'm going to come in here with my thenar eminence and I'm going to lock down C6. Where now C5 and above is all ready to float freely. So from here, Luke, I'm going to have you taking a nice, slow, deep breath. That's causing his ribs to expand, but I'm holding down C6, I'm sorry. C5, you can let out the air. C5 is now expanding and lifting up, becoming superior. So again, if those ribs were stuck together, you'd be on your way. So we're holding here, breathe in, and then breathe out. As he breathes in, it's almost kind of like a contract relax. C6 is trying to come up, but I'm pinning it down and I'm not letting it come up. And then as he breathes out, then it's the relaxation and I can almost push it further inferior. On top of the breathing, you then can also come in here and get a nice comfortable hold like we do with shoulder joint mobilization. And I can sit and distract his arm, which is creating some movement, of course at the scapula, but connecting to the ribs as well. So again, if I'm pinning down that segment, I can get a little rib distraction here. At the same time, maybe let me have you take a nice deep breath in and breathe out. And then I'm helping him there, and again, I can keep applying that distraction force. Okay, now we're going to try the lower rib separation mobilization. So with this one, we're going to imagine a lower rib, such as the rib that connects to T8 and T9. We'll call it the 8th and 9th rib. We're imagining those two ribs are close together, where then the ribs above and below it are separated out, like you see with my fingers. So similar to the upper rib mobilization, we're going to pin down that inferior segment and then try to distract and get this superior segment to move upwards. And by that, we then can create the gapping that is necessary to make it normal. So in this case, we can do, as it shows in the picture, they do kind of a web space grip where they're locking in on that lower rib. Sometimes I just use the side of my MCP or even a little bit of my thumb or even a combination of your fingers. It's whatever is comfortable for you and your patient. So try a few different holds, sometimes even like a thenar eminence here. So I'll kind of stick with that kind of MCP hold that works for me. Same thing. I can find that segment. Let me have you take a nice deep breath in and breathe out. And again, I'm holding that segment as he breathes in, getting that contract, relax thing. On top of that, I can then again get a nice comfortable hold on his arm, and I can be applying some distraction while pinning down that segment until that's all freed up. While Luke's putting his shirt on, I wanted to talk to you about a few things that are important with mobilizing the ribs. First of all, you do want to make sure the soft tissue is loosened up as best as possible before doing those mobilizations. You'll notice there are a lot of work on your hands. So if you don't have all the relaxation possible to those muscles, then those segments are going to stay close together and it's just going to be a lot of work. One good way to do relaxation, as he's showing us, is by doing some exercises. I'm going to show you one right now.
Hey, is that actually what you're talking about?
Yep.
Oh.
And then on top of that, you also many times, and it notes this in some of the slides, I think with the lower rib mobilization, that if you'll do a mobilization or grade 5 mobilization to the costotransverse joints first, so essentially go after the thoracic spine first and get all those joints loosened up. This is like what we talked about on Friday in class. Then from there, when you go after the specific ribs, like on the lateral surfaces, it'll make more sense.
Lights, camera, action.
Okay, so we're back here to do the windmill exercise. This is a great one we can do to loosen up the whole thoracic spine and ribs. I like to give this to my patients to do at home so they can maintain all the mobilizations we're doing in the clinic, but it's also a great warm-up and way they can loosen up before you're doing manual therapy on them. So with this one, essentially what I tell them to do is make the biggest circle they can with their arm, and that involves coming down here off the side of the table. So he's reaching down about 12 inches below the height of the table. Then up here, he's just trying to reach as high as he can, maybe in the plane of the table. And then it goes over the side, so he's along the table, and then he comes back around. Now the cue I like to give is watch your hand as much as possible as you do that motion. Now you'll notice as he does that now, ready? Reach down and around, watch your hand. Try to watch your hand the whole time. Watch your hand the whole time. See that? His thoracic spine naturally rotates with the motion here. And he gets all that movement through the ribs and the thoracic spine. Then of course we can have him come the other way. Now I want you to stay here, stay on this side. Now instead of like clockwise, counterclockwise, of course we do it the opposite arm as well. So now Luke, come back on your side. Starting here, now instead you're going to reach down first. Try to watch your hand the whole time. All the way up and then down. And now you're diving off the table like you're reaching down. And then come back up. And again, all that rotation. And then if you did that with his left arm, then he'd get that full rotation of the ribs and the thoracic spine there. Now we're going to get into some soft tissue techniques. Starting with the cervical spine and moving into the thoracic spine. So the first one we're going to work with here is the sternocleidomastoid, the SCM through here. As you can see that he was trying to help me and that just pops up through here. Now remember the sternocleidomastoid actually looks a little something like this. That sternal branch is coming from the sternum on top. It's the more superficial, with the clavicular branch going underneath and then thus attaching to the clavicle. So as you reach in through here, you'll actually, I don't think I can do this backwards with this hand, but you'll actually be reaching in that deeper pinch that you get, kind of like in the armpit, we were getting the teres major first, and then as you pull it out, you then were reaching the lat. In this case, that deeper bite is going to be the clavicular branch. And you'll even see sometimes that twitch response, or at least the top band, through that lower muscle. And then as you pull out where you think you're off the muscle, you'll then have a much thinner muscle, which is that sternal branch. And same sort of thing. Once you flick off that one, you'll see the kind of almost twitch response or top band going towards the sternum. And then of course those are up top attaching to the mastoid process. So what I like to do with this is just apply a light pressure, and I'm going to only squeeze for a couple of seconds at a time. And then if I really get a spot where they say, yeah, that's reproducing my headache behind my eye or back of the head, then maybe I'll stay there for 5 or 6 seconds and then I relax. But that's why I've been saving my pincer grip, my thumb, and fingers this whole time with our other soft tissue techniques, because you can't really come in here and pound it with your knuckles or fist, but you can definitely apply that gentle pressure. And then I might relax the neck and do the same thing on the other side. Sometimes it does make sense to just kind of rotate the head away a little bit. That'll help put the soft tissues on more slack, where if you rotate toward, that's tightening up those tissues. So not only is it giving you more room to work in here, but it also, like I say, puts that muscle on slack. So I'm just going along. This is what a treatment looks like. And whatever pressure they can handle, I'm essentially able to apply. From there, I'm constantly getting feedback if they're feeling lightheaded, if things are shooting down their arm, because that means you're probably in an area you shouldn't be. Of course, on the outer side, you get into the brachial plexus, and then the more inside you are, that's where you have the carotid. So, I mean, if you're really worried, you could even check the carotid pulse, know exactly where it is, and then just come out lateral to that. I mean, I'm an inch lateral to the carotid artery, so I'm really not worried about that. So the only thing left to worry about would be like the lymph nodes. So you just kind of get feedback about that, and that's kind of for another lecture. The next one we come to in the supine position would be the upper trap. And from here, as long as you're in this corner, right where my finger is, where the neck and the upper trap meet, and the upper back meet, that corner is where the upper fibers of the upper trapezius are. So from here, all you have to do is, again, maybe take a little bit deeper bite and get some of the levator scap. You can pull out until you're left with just this stringy muscle here. And that's going to be your upper trap, responsible for headaches and some of the upper neck pain. And then from there, I can trace that muscle, follow that string up. It almost feels like you're just following the skin up. And sometimes I think I'm on the skin, and then I'll pull more. I'll pull for a more superficial bite, and I'll notice I'm still on muscle. And then I'll go further, and finally I find just the skin. But again, it's just those most superficial fibers, and you can essentially follow those up to the cranium. And again, feeling for those top bands, those tender spots, constantly getting feedback from your patient to make sure you're using your time and your finger, that grip strength, wisely. Okay, if we're doing soft tissue work in the prone position, I think we talked about this in the shoulder unit, but we want to look for those lower traps. Those lower traps can cause headaches. They can cause upper back and neck pain. So looking for that lower trap, we're imagining where about T12 comes in, and then tying out to those shoulders. So if that's my line of force and that's how the muscle is laying out, then I'm essentially going to come, let me do it on this side so you can see better, perpendicular to those fibers. So on Luke here, see, I'm just moving in this direction. Again, kind of that 45-degree oblique angle, and I can feel those fibers running like this. Same thing over here. You're not going to be pinching here. This, you're doing more of that flat palpation, rounded fingers, supporting your fingers. And I'm just going along, trying to pin down that trigger point. And this is one where you'll see a lot of that local twitch response. When you finally lock down right on that spot, you'll see the twitching firing in each direction, down to T12 and up to the spine of the scapula there. From there, the paraspinal muscles, very much like the lumbar area, you can just move back and forth perpendicular on that, or if you want to get a lot of lotion, you could really knead through those muscles there. From there, you can work the upper trap and the mid trap through this position, in this nice prone position. You can also come in from here, not a lot of room on Luke, but on your normal adult patients, you can get that MCP and kind of dig into each side of the upper trap there, feeling the levator scap, as well as even getting into some of the rhomboids through here. Okay, in the seated position here, we're able to work on these upper traps here. Again, you can have a more rounded fingers and push down straight through those upper traps. And it's amazing how much muscle really is here. We were just pinching that top little portion when he was supine, but there's so much more thickness there and muscles to work through. So this is now your chance to essentially push through that here. We'll go from this way to essentially push through that entire muscle from that top-down approach. Then you can start moving downward, feeling where you imagine that levator scap coming through, and then down even into those rhomboids. And that's amazing if you remember how far down from the inferior angle those rhomboids will then shoot up. And that's all fair game for causing a lot of this upper back pain through here. The levator scap, the rhomboids, some of these paraspinal muscles, and even some of these kind of lower traps. Where everything upper tends to cause more of the neck pain and headaches. Okay, this is a good home technique for mobilizing the thoracic spine using the foam roll. So you support the neck here, and then you have you lean back, and then pick your, just like that. And now you're gonna slide back and forth, and that will help mobilize the T-spine. You'll get lots of cracks while you're doing that. And then when you find a spot that's a little bit tighter, you can then just try to bend backwards on it, almost like you're doing a reverse curl. Other thing you could do is cross your arms in front of you. That gets the scapula out of the way. So now you can roll back and forth. And that helps to get a little bit more of the musculature while you're doing it, as well as maybe a little more of the thoracic spine and those costotransverse joints. Okay, the next thing we're going to do, go ahead and sit all the way up. I want you to now sit on the end of that. Okay, now try to lay down. You can use your hands on the floor. So now you try to flatten everything out. This gives you great posture and helps you so your arms in a good position so you're not getting impingement. But for the thoracic spine, it's just a great way. You're going to put your arms together, reach up. Oh, keep your feet down so you can stay nice and balanced. Reach up. See, now you have all this extra room. And then slide your arms along the ground. And then back up again. So it's kind of arms together, reaching up behind you, down along the ground, back together. And it's good to do on that foam roll because then it really encourages you to reach far behind and get a lot of stretching to the pec. You can also just sit here and do snow angels. Okay, Luke is going to show us a nice doorway stretch. This is for the pecs. So let me have you raise up your arms a little bit higher like you're doing a Y. This is good for that lower pec, imagining those fibers coming down and attaching to that sternum. So now go ahead and lean forward. You'd hold that for 30 seconds. Then you come out of it, Luke. Now bring your arms down. So it's more like a T right there. And now lean forward. That would be the middle or both pecs. And then you come on out of it after 30 seconds. Bring those elbows down further, that W position. And then that's now going to get the upper pecs. You can also stretch one chest or one pec at a time by having an arm inside of the doorway. This tends to be a little bit more comfortable on the shoulders than the bilateral one. But if you're trying to save some time, no reason you can't do it bilaterally. Hope you all had fun. Please note any questions or comments that you'd like to discuss for Wednesday. Write those down now so we'll have those for tomorrow, and looking forward to working with all of you.